Um, welcome to Interventional Conference. I'm going to give a perspective on radial access. I have a lecture later on which I speak about the data for radial access and why we kind of are dedicated to using it, especially for angioplasty for PCI. But today I'm mostly going to talk about techniques and some tricks and tips on how to master it. So let's, we'll get started. I just, usually this lecture is split between Dr. Remitz and myself. Dr. Remitz speaks about femoral access and I speak about radial access, but I think the highlight of that debate is understanding that Dr. Remitz also has a large number of slides about femoral access complications. And this is my radial access complication slide. So I think that's the best way to put it in perspective. So arterial access, just to keep in mind some principles here. The key to arterial access is to find a safe location. So something that's easy to cannulate, as close to the skin, is away from other important structures, has minimal end organ risk if there's any trouble with disturbing the artery that you're accessing. Patient position has to be favorable, and then of course hemostasis has to be easy, and then the artery that you access has to be of adequate caliber for whatever you need to do. The radial artery is one of the few arteries that's not in a bundle with a nerve. The radial nerve is actually on the other side of the arm relative to the radial artery. The median nerve is on the same side as the radial artery, and the ulnar nerve runs with the ulnar artery, but the radial nerve and the radial artery are separated, which actually is quite convenient. The most important reasons in diagnostic catheterization that we think of when we're deciding about access is that you know, radial access allows people to get up early and it's safer to discharge them home same day. High risk patients such as those with bad peripheral arterial disease. And then in the next talk, I'll go through the data for acute coronary syndrome, why we favor radial access in ACS. A lot of data has emerged about the safety and benefit of using radial access in those patients with chronic kidney disease. I'll show a little bit of that today. But other important factors is that very large people are easier to access through a radial access site than a femoral. If patients have back pain or respiratory difficulty and have a hard time laying flat, radial access allows them to get up off their back and sit up quicker after the procedure is done. And those are not life and death things, but they are very important to patient safety and comfort. And patient acceptance, I think most patients who have had the procedure done through a radial access really prefer that over femoral access for a variety of reasons. I'm just going to highlight a few distinctions between femoral and radial. First of all, about bleeding and vascular complications, renal function, and then fluoro time and radiation exposure is often discussed. And it's important to understand what the real issues there are. So bleeding is really a key factor for coronary angiography, coronary intervention. And bleeding avoidance is really an emphasis of learning how to do this correctly. This is just one example of a large body of data that exists showing that bleeding at the time of the procedure has an impact on mortality over the long term. So this is 5,000 patients in 4 separate trials in elective angioplasty, and you can see a real mortality difference there at 12 months between those who had any bleeding episode at the time of the procedure and those that did not. And this is, as I said, it's one example of a large body of data that comes to the same conclusion. The Matrix trial, which was a randomized trial between femoral access and radial access, showed the same data. This is all-cause mortality in the upper left panel. And then BARC 3 and 5 bleeding is down here. And you can see that most of the events are driven by bleeding. So this is Bleeding Academic Research Consortium definitions of bleeding. And, category 3 and 5 are those bleeding episodes that are actionable and are directly related to the procedure. Just a little bit about the anatomy. This is the elbow joint up here for orientation. So the brachial artery is in the upper arm. It comes distal and divides into the ulnar and the radial. The ulnar goes along the ulnar surface and gives off an intraosseous artery. In this particular angiogram, it looks like the radial is larger than the ulnar. In general, they're about the same size on average. Sometimes the ulnar is bigger, sometimes the radial is bigger. But we favor the radial for several reasons. And this connection between the radial and the brachial artery is really critical to understand when you access the radial artery. The hand has blood supply both from the ulnar and the radial artery, and there's a rich network of connections between the ulnar and the radial. It's often thought of two arches, a deep palmar arch and a superficial palmar arch, but actually the connections are quite dense, and loss of either the radial or the ulnar will rarely cause any clinical evidence of ischemia because of this intense network of connections between the ulnar and the radial artery. The Allen's test was something that a lot of people talked about, and you may read about Allen's test prior to radial access. This idea that you need to assure connection between the radial and the ulnar is now pretty clearly a historical artifact. We really don't bother with checking Allen's tests anymore. And here's some of the data about that. It's really not necessary to check that integrity. Should you use the left or the right radial? Different operators have different opinions about this. This is definitely stylistic. There are some labs which are set up primarily for left radial access. In general, the left radial will give you easier access to the ascending aorta in almost every patient. We tend to use the right radial as our primary access, which most of the time the innominate artery will point you down the ascending. But there are some people, especially as you age, the aorta elongates and the innominate moves over toward the center or the left chest, and then it can be quite an angle coming in from the right side to get back into the ascending aorta. So in general, if you're going to do an angiogram on somebody who has bypass grafts, you need to come from the left side so that you can get the mammary. My rule is, once you get above 75, you should really strongly consider left radial access. And then very short people too, the kind of ascending is really short, and this angle can be tough to get down and get your catheters in a good situation in the sinuses. And so Those are the three situations where you may favor left radial access. Our labs are set up so that the operators stand on the right side of the table. And if you do left radial access, there's a variety of ways that you can bring the arm over toward the right side of the left arm toward the right side of the table so that you can still stand on the right side and have access to the left radial artery. So how should you go about radial access? First of all, it's really important to make sure the positioning of the arm is correct. This is something called the radial assist board or RAD board. This has a little diagram. You can see some outline here where the arm should be and the hand should be. Very often you walk in the room and the hand is draped over this end of the RAD board, and that's not really helpful. You really want to use this and have the wrist at the head end of this board so that you have a working surface. Other times you won't see this board being used. They'll use some other prop device. But the key is, if you're going to do this, especially for the interventional fellows, if you're going to do angioplasty through a radial access, you really want to make sure that you have a flat working surface to the feet side of the wrists so that you have something to work on so that you're not hanging off the end of the table. Then you want to, usually there, I don't know how I can.
Oh.
There's little devices. This is a styrofoam device to extend the wrist and prop it open in this correct way to make sure that the radial artery is moved toward the surface and the hand is out of the way. These are some Velcro straps that hold it on. So it's key for you to come in the room and make sure that the techs have this positioning done correctly. I encourage everybody to go in the room before you get your lead on, before you get prepped, to go in and make sure the arm is positioned to your satisfaction, and that you can feel a nice radial pulse before you prep the site. And this all goes under the blue tray. Because if you can't feel the pulse here or the patient's not in a comfortable position, this is the time to reposition, not after you've put the drape on. So it's really key for you to kind of be in the room when the patient is being positioned on the table. Make sure that the patient's comfortable, make sure that you like the position, that you can feel the radial pulse easily. This is what it should look like once you're draped. You have your radial access site here. You have a nice flat surface on which to work with the radial board going to about this level. And this makes it very comfortable for you and a decent work setup that makes it easy to accomplish what you need to accomplish. Obviously, pre-procedure sedation is key for any of our procedures, radial or femoral. There's some operators who suggest a sublingual nitroglycerin as you get started, which will increase the size of the radial artery slightly. The other important difference between radial access and femoral access is to really minimize the amount of local anesthetic you use. In femoral access, there's quite a distance usually between the surface of the skin and the femoral artery, and you need a good amount of anesthetic to make sure the patient's comfortable. With radial access, you really just need to raise a small skin wheel over the radial pulse. The radial is so superficial that if the patient feels the needle when it goes in deeply, that means you're past the radial artery. So you really just need thermal anesthesia. and nothing deep. And you don't want to inject the sub-Q tissues around the radial artery because that may result in spasm and make your job harder. And just one other point, it's helpful to identify the major flexure crease in the wrist. There's usually a bunch of skin creases here, but the major one here, you want to go about 2 centimeters towards the head to find the best spot where the radial is most superficial. It's fixed in space because there's a bone underneath it, and it won't move left to right at all either. As you go more proximal, it moves away from the bone and it becomes more mobile, and it's harder and harder to access the radial as you go towards the elbow. So 2 centimeters from the major flexor crease is really the sweet spot in most patients. There's 2 ways to access the radial. The classic cell ligament technique is to use a gel cath or angio cath, which has a needle and a plastic covering. This is just bring the plastic catheter back until you're within the artery, and then you'll have pulsatile flow out the back end. And you can advance the wire through the plastic catheter. And then once you have the wire securely in the artery, then you can advance your introducer sheath over the wire. Many fellows who come through from other institutions are more comfortable with this. Some of our own operators are more comfortable with this. My own bias is to use a single wall technique where you just use a needle and a straight tip wire. The straight tip wire comes in the radial sheath kit. And this wire is decent. You'll be able to use it in 80 or 90% of patients, but some patients with a lot of curvature or tortuosity in the radial artery, this wire that comes in the kit is not that friendly and it won't negotiate those curves. And so then in all the labs, there's a wire called Nitrex, which is a nitinol wire, which has a tungsten and gold angled tip, which is quite friendly and will really navigate all the curves. It's a little too expensive to use in every single case, but if this wire won't advance past some tortuosity, then the Nitrex wire is almost universally successful. We use either a 16 or 11 centimeter hydrophilic sheath. It comes in 2 kind of arrangements. The standard sheath is a little thicker. The slender sheaths are thinner, and for the same French size are significantly smaller. And I have a diagram of that upcoming in another slide, and I'll point that out. Once you get access, depending on the patient, you can use a J-wire, but very often the J-wire fails to navigate the radial artery, and you'll meet a lot of resistance trying to get into the brachial. So my bias is to use a straight floppy tip 035 wire, which will get through all the angles in the arm and get you to the innominate artery just fine. Versacor or the VSI are the 2 brand names that we use of this wire. It's just a straight tip, which is easier. Once you get the sheath inserted, there's some people who believe that you can give a little cocktail through the sheath, like nitroglycerin or verapamil, which would prevent spasm. The key to prevent spasm in my mind is sedation. It's rare that you really need anything else except good sedation. We always give systemic anticoagulation with IV heparin. because doing radial access for a diagnostic catheterization without any heparin will result in more radial artery occlusion. So we definitely give heparin once we get access to kind of make sure that that radial artery stays open after we're done. This is just from a survey of radial operators to show you that, you know, the different permutations of little cocktails that they may give through the sheath to prevent spasm. Nitro and verapamil are kind of the most common. About 15% of people give nothing. I'm in that 15%. Radial spasm. It's very important to understand there's radial spasm, and then there's resistance due to tortuosity and sometimes even atherosclerotic disease. The things that predict spasm is female gender and diabetes. It turns out that the older you are, the less spasm you have. So if you're doing radial access on a 40-year-old woman, I think that's really the time when you have to pay attention. And radial spasm also predicts radial artery occlusion after you take everything out. So it's something to be aware of, but you should know that there's a difference. Radial artery spasm is very painful. It makes it very difficult to maneuver the catheter. There is some resistance where the patient won't complain at all, and that's usually related to tortuosity or disease. If you feel spasm or if you feel resistance, it's also important to recognize that not every radial artery connects to the brachial artery the way that nice angiogram I showed at the beginning demonstrated. There's quite a variety. And most commonly, the radial artery will connect higher up on the brachial artery or the axillary artery. And when you have these long radial artery connections, those vessels tend to be smaller in caliber, and they'll give you trouble in terms of spasm or difficulty moving catheters. Very often there's two arteries, one connection up here, and then there's a bridge over to the brachial kind of in the usual location. It may be larger or smaller, but when you first start and you send the wire up, the wire may go up this accessory radial or this accessory connection of the radial, and then you'll have difficulty moving the catheter. And then if you come back and take an angiogram of the elbow area, then you'll be able to identify which of these anatomic variations you're in. And oftentimes you just need to redirect the wire into this connection and get into the brachial and out of this accessory. And, you know, very often these high bifurcations result in failure of radial access. So just important, this is what diffuse spasm looks like if you do an angiogram. This is much more common. And this kind of tortuosity is why the wire that comes with the radial sheaths may not negotiate this kind of wiggly radial artery, but the nitrex wire will. This is just an example of a couple of variations of the radial connection to the brachial. In this case, the radial artery is here. It continues to connect way up here in the axillary artery, but you see this nice big connection over to the brachial. And so this was easy to access. Once you have this angiogram, then you can just redirect the wire. Sometimes you need a coronary wire or an angled glide wire, but you can get around this easily and get into the brachial and complete the procedure. In this case, you don't see the brachial, but it's right here. And then this is the ulnar artery. The radial comes up here and then continues up to connect up high in the shoulder. But this is a 360-degree circle here between the radial and the ulnar. And that can be difficult to navigate and to get around and to straighten out. And very often, if I see this kind of a connection, then I'll either move to ulnar access or femoral access, because that's difficult for you and can be very painful for the patient. Occasionally you can navigate these. This is one that we used kind of a slippery angle glide wire to get around the loop. And then you'll see that as you push the wire up and then advance the catheter through this loop, it'll straighten out. And then you can go ahead and advance it up into the brachial. So the loops are often, when you have these anomalous connections, you can get through them. Sometimes they'll straighten out like this. This is a young person with nice floppy arteries, but a lot of times you won't be able to straighten them out, and it end up being painful for the patient and painful for you. You can also have loops higher up. This is a brachial artery loop. This you would straighten out pretty easily if you were to take a wire and pass the catheter through that. The only difficulty with this kind of a loop is that you kind of shut off blood flow to the forearm, and the patients may complain of their hand being asleep. And this will pop back open and restore flow once you're done with the procedure. But if you're doing a long procedure like an angioplasty, then it may be pretty uncomfortable for the patient. Radial artery occlusion is important, anywhere from 3 to 10%. And the most common predictors are spasm or low or no heparin dose. So most of us give 4,000 or 5,000 of heparin. You can certainly give up to 7,000 units of heparin. There's no trial that has looked at a graded dose. There's a lot of small studies that compared 3,000 to 7,000 or 3,000 to 1,000 or 4,000 to 2,000. And in general, the higher you go with your heparin dose, the less radial artery occlusion there is at the completion of the procedure. The other important thing to prevent occlusion is to kind of make sure that you don't damage the artery. You really don't want to put a big sheath in a small radial artery, and so you want to try to keep the sheath artery ratio as low as possible. So if you're cathing a 6'2", 250-pound guy, almost any sheath you'll be fine with in a radial artery. If you're doing a procedure on a 60-kilo, 4'9" woman, then you really have to downsize your sheath size 5 French. And this is just a demonstration of what the standard sheath, 6 French sheath, gives you a diameter of 2.65 millimeters, the outer diameter. And then if we use the slender sheaths, the walls are thinner, and so that outer diameter is less than 2.5. So it does shrink it down and provide some less damage to the radial artery. But the key is to kind of make sure that you match your sheath size to the radial artery size, and avoid really severe damage or dissection. Many arteries will have dissection after placing the sheath, and the more of a mismatch between the sheath size and the artery size, the more likely you are to lose that radial artery after the procedure. So prevent spasm, give anticoagulation, match your sheath to artery. And then there's this concept of patent hemostasis. This hopefully the experienced fellows in the lab are doing this already, and we'll kind of walk everybody through this. But you want to apply the compression device, and then once the sheath is out, you kind of decrease the pressure on the device until you see pulsatile flow. That means that the radial artery is patent, and you want to add just enough pressure after that so that there's not external bleeding, but the radial artery is still patent. And you can evaluate this by putting the oximetry plethysmographer on their thumb or their index finger and make sure that there's pulsatile flow there. That usually means that the radial artery is patent. And if you compress the ulnar, you should see a nice waveform on the index finger from radial artery flow. If you don't have a nice waveform, that means that the radial artery is probably not patent and you need to decrease the pressure on your device. And then, leave those hemostatic devices on the wrist as short as possible. The sooner you get them off, the less likely you are to have radial artery occlusion. And this is kind of, if you do lose the radial, then you can flip the device over, compress the ulnar, and then that will kind of force blood down the radial, and very often that'll reopen the radial artery. So if you do your test, you come up to see the patient afterward, there's no radial artery flow, then you can flip the TR band over and try to get the radial artery to open. Vascular complications, the overall incidence is similar in diagnostic cath. There's not a big difference. You can have subclavian or autonomic dissection or perforation as you navigate. Radial perforation is not uncommon, but is usually kind of a minor issue. I've seen a couple of pseudoaneurysms in the radial, but they're the tiniest thing ever, and you can make them go away usually just by a little pressure for an hour or two. Radiation exposure, I think the literature in general kind of states that radiation exposure is higher with radial cases than femoral cases. Most of that data comes from the early studies of radial versus femoral access. Radiation exposure, this, for example, this is the Rival trial, which was a randomized trial between radial access and femoral access. And here you can see 9.8 minutes of fluoro from radial access versus 8 minutes of fluoro from femoral access. But this really depends on operator experience and institutional experience. And so I think as people get more experience, these times really kind of come together. And in general, the radial position for the operator should be very similar to the femoral position and have very little difference in radiation. But the literature does kind of say the things that are out there in randomized fashion, there's a little bit more radiation time with radial access. Kidney disease, interestingly, for whatever reason, nobody really understands this very well. Kidney injury is less with radial access than femoral access. The Matrix trial, which I'll go over on my next talk, was randomized femoral versus radial. And one of the observational findings from the Matrix trial was that there was less kidney injury. So they went back and did a randomized study, AKI Matrix. And you can see the primary endpoint was reached less often in the femoral in the radial compared to femoral. So contrast volumes end up being similar. Nobody really understands this very well, but it is kind of a very reproducible finding that there's less kidney injury by radial access. This is a nice kind of summary, both of transfusion rates and progression to dialysis in patients with chronic kidney disease from Sunil Rao, showing that both of those endpoints are lower with radial access compared to femoral. Just a few words about other upper extremity access sites. The ulnar is just as good. It's a nice caliber vessel. It tends to be straighter than the radial, less no anomalous connections and less tortuosity, and so it can be a very nice access site. The only disadvantage is that it's deeper. And so I would encourage everybody to use ultrasound if you're going to do ulnar access, because it's a little harder to feel the pulse and to kind of stick it directly. Also, there's not as much underlying bone. It's not directly over the bone. And so that hemostasis does require a little bit more aggressive pressure to really get it compressed. You know, it turns out there's no increase in complication rate. Even if you've had failure of radial access on that same arm, you could go ahead and flip over to ulnar access and complete the procedure through the ulnar. So it is a nice bailout if you can't access the radial, or if the radial is occluded, you can safely use the ulnar on that same side. And it is a nice way to kind of bail out if you can't get radial access on that side. This is a consensus statement from the Society for Cardiovascular Angiography and Intervention, you know, from last year, which basically says that radial is preferred, but you can go ahead and use the ulnar. Data on using ulnar on the same side is limited. It's there. There are that's plenty of studies, but the number of studies and the number of patients involved is relatively small. But I think it's safe to go ahead and use it. What about distal radial access? You know, the so-called anatomic snuffbox access. So if you look, our usual radial access site is here, and we're just going to access it a little more distally, maybe 2 or 3 centimeters further distal in the hand. It's helpful in 2 situations. Number one, there are some patients, because of prior shoulder surgery or arm injuries, who can't lie flat on a table and have their palm directed up. And if you use distal radial, you can have their palm flat down or laying at their side. It's also really convenient for left radial access, where the patients really can't keep their palm up when you pull the arm across from left to right and you're working on the right side of the table. It is difficult to feel the pulse in this particular location. Ultrasound is almost always necessary and encouraged. Use ultrasound to access the radial artery. This is the location of the anatomic snuffbox. With the thumb extended, you can see the extensor tendon of the thumb here, and there's a little triangle, and the radial artery is right there. It turns out that the best way is actually to have the patient put the thumb in their palm of their hand, and that forces the radial artery up toward the surface. So you can identify this area and mark it before you prep and drape the hand. But then when you do the access, it's recommended that the thumb be abducted and kind of held by the fingers to force the distal radial toward the surface, and then use ultrasound. And so this is kind of what you see. This figure is important for 2 reasons. You can see this is where we usually access it, and this is going to be the anatomic snuffbox access site. So it's really close, about 2 centimeters. But this also shows you why many people report that radial artery occlusion is much lower using this access site, because there's other branches. If you thrombose your access site here, there's no real branches, and so basically occlusion of the radial artery propagates back to the bifurcation from the brachial. But if this access site occludes, there's still good flow down the radial, because there's branches upstream, large branches upstream, that'll maintain flow in the radial artery. So the data is still out, but it appears that radial artery, loss of the radial artery, is less frequent when you use distal radial access. it's absolutely necessary that you use ultrasound. Feeling the pulse here is really difficult. And then you can use the same radial occlusion devices like a TR band, which is what we have in that site. You just have to put it more distal on the hand. This is data on one study of about 300 patients showing a radial access occlusion with distal radial here in red and the standard radial access 8%. So stay tuned. This data is still emerging, but at least in this study it's suggested. And then there's other kind of crazy access. This is a paper describing accessing the superficial palmar branch of the artery here in the hand, which that looks really crazy to me, very uncomfortable, but I guess it's possible. I think that's my last slide. I'm just going to say that, you know, it's really essential. You have to, in the current era, be able to do both radial and femoral access. And I'll go over the data why we favor radial access so much in my next talk. There is a learning curve both to doing the access and getting the catheters to sit in the coronaries. The data suggests fluoro times are longer, although I would say that with experience, the fluoro times come together between femoral and radial. The data definitely supports improved outcomes in acute coronary syndrome, mostly mediated through lowered bleeding rates. Kidney injury is less for reasons that are not well understood. The added benefits is that you get early ambulations. The patient really likes it, especially if they have lung disease or back pain that limits their ability to lay flat. It's really nice. And there's plenty of other alternate upper extremity access sites with equal or perhaps improved outcomes if you believe the data on distal radial access. So with that, it's 8:15. I'm going to turn it over to Dr. Alton, who's going to speak on